active component. This is a super big blown up blood cell. It keeps it stuck out here and out of the nucleus where this actually does all its work. So it's a way of blocking this that enzyme, this NF-kappa B. And so bortezomib and the other drug carfilzomib, which is generic for Kyprolis. So Velcade and Kyprolis work this way on the cell. And it just turns out that myeloma cells really need this to work in order to survive, or at least most of them do. So blocking that kills the cells. So as an example of how this works, people back a long time ago, the treatment was thalidomide and dexamethasone. So 15 years ago, or thereabouts, if I saw somebody with multiple myeloma and I was going to start them on treatment, I and many other doctors, this is what we give them. I usually only gave 100 milligrams of thalidomide, but that's beside the point. Then we give thalidomide and dexamethasone. And so this bortezomib, Velcade came around, and so this was from a while ago. But they compare, what about if we add Velcade to the thalidomide and dexamethasone? Does that make things work better? And if you look at the light blue, that's how many people went into remission with thalidomide and dexamethasone. And then in the darker blue, that's how many people went into remission when you added Velcade. So obviously the number of people responding is better when you added Velcade to the two drugs. As you can see by these numbers though, it's not 100%. So again, everybody's different. Then after the transplant, the transplant hits it again, and here's the number of people. Actually, this 55 compares to this number. So the 32% of people goes to 55%. So again, usually the transplant kills cells. It just comes down to whether it was worth going through all that to get to that point. Now the problem with Velcade is that, one of the problems, that all drugs have side effects. Some people take the medicine and they literally ask me, why am I supposed to feel badly after they're on it? They really get lucky. Their treatment that they're taking doesn't bother them at all. So it's either the only problem is it's a nuisance, or they have to pay for it, or a combination of the two, but they have no side effects and it works beautifully. And they just got, that's wonderful. But not everybody's so lucky. A lot of these drugs have side effects. That's why there's a dose for these drugs, because if we give more, the side effects would be even more. So the main side effect that people have to watch out for with Velcade is on the nerves. It's peripheral neuropathy, which is damage to the nerves. And the drug, for some reason, tends to do that. And it builds up over time. But once, it seems like you either get it, if you're going to get it, it's in the first, 6 or 8 months. Then if you can go beyond that, usually people don't get it so much. So some people are just, their nerves were, not as sensitive to the drug. If you recognize it and tell the doctor in time, it can get better. But that number is not 100%. Unfortunately, it doesn't always get better. And a lot of times it improves, but doesn't improve completely. So the important thing I would say for you all that might be taking Velcade is that you have to let the doctor know. It's a judgment. It's like if I feel, patients, if I feel a little tingling in my toes, is that enough to change the treatment? It depends. I mean, I'm more and more, if people start having nerve problems from the drug, it's time to lower the dose. Because if you keep doing it, it just keeps building up. But, if I felt a little tingling in my toe for a couple days and it went away, well, I'm probably going to keep giving this drug because, I'm not sure. Maybe it wasn't the Velcade, maybe it was something else. I want to give the drug a chance to work. And then, sometimes things happen by surprise. So, yes?
Is the Velcade taken with the thalidomide or instead of?
You can do either. So, there is, it's like a... maybe that sounds bad, but it's like a bartender. You there's all kinds of things you can put together, and some things work better when you blend the three. You know, you can put three things together, but certain three things won't work so well. So if you, that Velcade, thalidomide, and dexamethasone, that's used a lot in Europe. I don't think that particular regimen is used a lot in this country because thalidomide isn't used as much anymore in this country. In Europe, thalidomide, Revlimid is not paid for so very easily, so people are, you know, less likely to use Revlimid with Velcade. But you can do it by itself. I usually do Velcade and dexamethasone, and Cytoxin is the one that I give. But other people give, you know, Dr. Berenson likes to give Doxil instead of Cytoxin. You know, a lot of places give Revlimid instead of Cytoxin. So you can do, it depends. It depends on how, you know, you start adding 2 and 3 drugs together, three drugs together, it may work better or more quickly, but then you're going to get the side effects of 3 drugs rather than 2. So that's why you have to individualize it for a patient. If I have a 90-year-old, I'm not going to throw, you know, 3 drugs at full doses at that 90-year-old to treat their disease. I'm going to be a little more gentle on them. So in Europe, what happened is a nurse, by mistake, was giving the Velcade, or bortezomib, is the generic name for it, gave it as a shot, like in the belly, instead of in the vein, like the way everybody was supposed to give it. And that person's myeloma did fine and responded. So then they thought, well, that was bad, you shouldn't have a mistake, but it looks like you can do it that way. And shots are easier than putting it in the vein, because, you know, I'm sure everybody that's had an IV started, that's never 100%. So they decided to just compare the two. So to compare Velcade given as in the skin, in the belly, or, you know, thighs, versus in the vein. And they treated the same type of people with multiple myeloma, and basically what they found was the response is the same. So that wasn't so surprising. The people that got the shot in the abdomen were just as likely to respond as the people that got the Velcade as in the vein. Not everybody responded to either, but the same, you know, 60% or 50%, I think it was, responded from both groups. But what they noticed was that if you look at the nerve damage, the neuropathy, it's less in this column, the shot, versus the IV column. So especially grade 3, we kind of rate how bad neuropathy is based, you know, we grade it. Grade 1 is you notice it, grade 2 it bothers you, grade 3 you need pain medicine for it, grade 4 it's crippling. That's kind of an easy way of thinking about it. And we never want to see grade 3 and grade 4. And that really was less. We went from 16% to 6%. So that's why we typically give Velcade as a shot instead of in the vein now. The only trade-off, though, and I'm sure everybody that's had Velcade that way knows, and I don't know, you know, this, they talk about like severe, but everybody that's had Velcade, they know you get a red spot that kind of burns, and it's like an irritant. It's like getting a mosquito bite or worse in your abdomen. So that's the trade-off. You don't get that if you get it in your vein. So we now mostly give the Velcade that way. So then the next drug that come around was lenalidomide. It's a fancy way of saying Revlimid. So this is phthalimid. And for all you chemists up there, that's the molecular structure of phthalimid. And this is lenalidomide. So you can see, if you kind of compare, they kind of look the same. Except this one has an oxygen group, a ketone, and this one has an amine right there, nitrogen group. Just that difference, though, made some of its effects much more potent. Maybe that's not the thing that's important to make different, but it alters the way it works in some ways. It makes it more potent on average, but it changes it. It's a different drug.
But not for everyone.
not for everyone. So I have people, when this first happened, 10 years ago, people were, when Revlimid was coming out, or 8 years ago, whenever it was like, well, are we just going to abandon this drug? Because, this one's more potent in some things. Well, it's more potent in some things, maybe less potent in others. And so it depends on somebody's myeloma, what drives that cancer. So for some people, the thalidomide is the better drug. I have definitely seen people where Revlimid was not working and thalidomide does work. So I would say that's not super common, but I definitely have seen it, absolutely, without doubt.
And why does an amino group work better and not the combination group? Nobody knows.
No, I don't think people know. And again, that's just for for one person. For somebody else, it's this one that works. So at the moment, the way we figure these things, it's you find out it works, and then it's still just it's still kind of trial and error. And then fortunately we have tests to see if something's working. If it's working, then you continue. And if not, you got to switch. So the main study that was done looking at how to give Revlimid or lenalidomide was this one. Back in the old days, people that took myeloma treatment 15 years ago, the dexamethasone was given 4 days in a row at 40 milligrams, so 10 pills, 4 days in a row. And then you would take a 4-day break. And then you would do another 4 days, that's 40 milligrams each. And then you would take a 4-day break. And then you would do another 4 days of 40 milligrams. Now, people can't do that forever. That's a lot of steroids. But you can do that, and it commonly was done for a few months to get things going. So when they first did Revlimid, that's how they gave it. Revlimid with 480 milligrams of dexamethasone in a month. You kind of figure out the math. That's a lot of steroids. So they compared it to low dose, and actually the myeloma support group is what kind of came up with this low dose regimen. Because people said, well, that's a lot of steroids. I hate those steroids. Why can't we get by with less? So that was the study. And they tried a lower amount, and it turned out that this way of giving it worked not as quickly. This way worked faster because it's more aggressive. But in the end, the people actually that got this way did better than these, because these people had lots of side effects, infections, blood clots. Whereas if you don't give so many steroids, people tolerate it better. These were for brand new diagnosed people, so people that hadn't been treated at all. This was like, you find out they had myeloma, okay, you either do it this way or this way. And then some of the people went on to have transplants. So some people just stopped treatment, some people had the transplant, some people stayed on the Revlimid and dexamethasone. And so one of the questions, and again it's open for debate, there hasn't been a great study, but this is probably still the best study in the current era, looking at how valuable transplants are. While the people that stayed on Revlimid, 20% had passed away after 3 years. The people that did the transplant, only 8% had died after 3 years. Not a huge difference, but enough if, 8 to 20 versus 21 is enough of a difference to say it may be helpful to do the transplant. This just kind of throwing up some combinations, and there's no right answer. But if people start doing Velcade and Revlimid and dexamethasone, so all the drugs I showed you earlier, you can see 93% of people respond to the treatment, or Dr. Richardson's study, 98% did. So, at least at diagnosis, if you give 3 good drugs at the same time, people tend to respond. This is with the cytoxin.
How long does this all last, doctor?
It varies tremendously. So it's, you know, everyone in the room has got a different myeloma. I don't know if you guys want to talk a little tiny bit about transplants, or we know kind of what transplants are?
I do.
Want to talk about it? Okay. We'll just go briefly through it. There's two types. So, and I don't know how, I think it's Greek or Latin or something like that, how they came up with these terms. Took me a while to figure these out. Autologous, you use your own.
Right.
Allogeneic, you use somebody else's. And that makes a big difference on how aggressive the treatment is. There's a lot of extra side effects you get when you use somebody else's cells. So when we use your own cells, you can't take your, you can't like, okay, let's say I have multiple myeloma, I can't just go, I mean, you could, but you probably can't just do a transplant right from the beginning. The problem is usually if I had myeloma, my bone marrow is kind of sick. That's how I knew I had myeloma, because I feel tired, I'm anemic. So if you're trying to collect seeds to regrow your bone marrow from a bone marrow that's working at 20% capacity, efficiency, you're not going to be able to collect many seeds. So we don't do transplants, you know, right at diagnosis, because people are usually more sick at diagnosis. And the good news is we have treatments that work. So 90% of the time, treatment that you get started with nowadays is going to work, make the myeloma better. So that's what we do first. We first try to get rid of most of the multiple myeloma. Get the cancer controlled, get people where they're feeling better. Then we have to get those stem cells, blood stem cells. Well, normally they're in the bone marrow. And back when I was at UCLA, we'd go in the bone marrow to get them. And I hated doing that, and so does pretty much everybody else I know, the doctors, because it's just not a very pleasant thing to do. And it requires a surgery. And frankly, some of the research, one of my papers I wrote a long time ago, proved the obvious, that if you take if you collect the stem cells from the bone marrow, well, that's where the myeloma is. So you collect a lot of myeloma with it. If you collect it from the blood, well, sometimes you can't even find it in the blood. So you can collect the stem cells and have it be free, or much, much freer of any contaminating myeloma cells. It's not clear it makes a difference, but it just kind of intuitively, it sounds better to have, you know, something without any myeloma cells in there that you're going to give back to a patient than collect it where the myeloma cells are. So we have to coax the stem cells into the bloodstream, and in order to do that, you either do shots, these Neupogen shots that give people lots of achy bones, make their bones ache, or sometimes we give chemotherapy first and then the shots. You do the chemotherapy with the shots, you get more cells. You give the chemotherapy, though, you get side effects from the chemotherapy with your hair. So it's there's positives and negatives about doing the chemotherapy with the shots to get the stem cells. And then once the stem cells are out into the bloodstream, we collect them and we count them. Because on the surface of the cell is this protein called CD34. I couldn't tell you what it does. It's just the 34th protein found on blood cells. So that's how they identified it, and it seems to be found only on the stem cells, not on other cells. So if you find a blood cell that has CD34 on it, it's one of those cells, it's a stem cell that can regrow other cells. So those are the ones we count to make sure we have enough of the seeds to regrow the bone marrow. And then the treatment, this is not always clear. The treatment for a transplant is the 1 to 2 days of chemo you get before the transplant. That's the whole meat of the treatment. You give a drug that just kills bone marrow cells, myeloma cells included, just wipes them all out. And then, once the drug's out of your body, which your body gets, you know, the body metabolizes things. You take a pill, you have to take a blood pressure, but you got to take one every day. If you take it today, it's not around the next day. So the chemotherapy, even though it's a big dose, that drug gets cleaned up pretty quickly by the body. Every 90 minutes, half of it goes away. So by the next day, it's basically gone. And so then you put the new stem cells back in. And the cells that were exposed to the chemotherapy are going to die. They were injured by the chemotherapy. They don't die tomorrow, but they will slowly die off. So it's, that analogy is like if, not that I use a lot of this stuff, but you know, if I go out in my lawn or my yard and I see some weed in the, you know, creeping up on the cement, and I spray it with Roundup, and I go inside the house, and 3 hours later I come and look at that weed, and the weed's still there. And I come maybe a few hours after that, the weed's still there. But that weed's going to die if I spray it with Roundup. So that's basically what happens to the myeloma cells. They're going to, and the regular healthy bone marrow cells, they're going to die. And then you put back in the new cells, and they take about 11 days for the new white blood cells to grow back. Sometimes 10, sometimes 12, but pretty much very consistently 10 to 12 days. And then the body, the white blood cells can heal you from the chemotherapy. But the problem is, really, it's that this big dose of chemotherapy is a big dose of chemotherapy. It makes people sick. So you get nausea, you get diarrhea. I mean, it makes you sick. And the other problem with this is that, you know, if this was perfect, if this statement was perfect, you'd cure myeloma. Because you just kill the bone marrow cells and you put the new ones in. We'd be done. The problem is it kills a lot of the myeloma, but it doesn't seem to kill every last one. Some people get lucky. I've had people, I saw earlier this week, he had the chemo a long time ago for 6 months. He had the transplant, and it was 11 years ago. And he's still waiting for his myeloma to grow back. So for him, I can tell you with certainty, the transplant was a beneficial thing for him to do. I mean, he felt badly for a month, 2 months, and then for the next 10 and a half years, he's been just fine. You wouldn't know anything's wrong with him. Unfortunately, that's one end of the spectrum. There's some people who go through the whole thing, and even 6 months later, rarely, but it does happen, the myeloma can be grown back. So obviously somebody like that, it wasn't worth all that headache to have it just only work for 6 months. Where I think you can really make a difference is to stay on some type of treatment afterwards. Because if the transplant, if I knew you were going to be like that gentleman I saw earlier this week, he happens to not even be on any maintenance treatment. He just basically hit the lottery, and it just all worked. So he's the winner. But I didn't know that he was in a study, and we didn't give maintenance treatment so often back then. And I don't know. I don't think any doctor knows going in if somebody's going to be like him, or somebody's going to be, where the disease stays away for a few years and then starts coming back. So usually, in my belief, is that once you get the disease under control, you stay on something to help the body keep the cells from growing back.
I thought this was why we really tend to stay away from using the term remission with our disease. This is the first time I've ever heard you use it. I thought it was just something that we didn't talk about with multiple myeloma. There was no such thing as remission.
There's a thing with remission. It's hard to say people are cured. So remission means it can't be found. I have lots of people in remission. If we come up with a better test, like when that free light chain test came out, that a lot of you, I'm sure, get, that all of a sudden was able to find the myeloma when there was less of it for many people. So some people that seem to be in remission, all of a sudden they get the test, oh, and you can still see it. So remission means you can't find it. Cure means it's gone. So the problem is, you know, I may have myeloma. Nobody's found it, you know. I won't know till it starts to bother me. So that's the problem with the disease is I don't know. If you can't find it, we call it remission, and then we're kind of running a little blindly on whether a treatment's working or not working. If you're on a treatment that puts you in remission, the assumption is it must be killing, you know, hard on the myeloma cells, make them not grow as well. So that's why I like to keep people on it. Yes.
Is the term stable identical with remission?
Not necessarily, no. Stable means the disease has been, enough of the myeloma has been eliminated to where it's not bothering somebody. But that stable just means it's not growing. So some people, when you start them on a treatment, the disease is stable, which for some people that's not good enough, because when the treatment was started, they actually were sick. So you want something better than stable. For other people, you know, people feel fine and their disease is still there, but it's not hurting them, so stable would be fine. You don't, I mean, you don't have to get rid of every last myeloma cell. That would be nice. That would certainly be what I would want to do. But sometimes in order to do that, let's say you had to do 10 transplants. Well, you know, I don't know, it's worth it. So you kind of settle for keeping it from growing to harm you.
And can you relate remission to the terms like complete response, partial response?
So remission just means you can't find it with the tests that we have. So partial response is that there's been an improvement, there's less of the cells, and we measure that by the protein that the cells make. So there's the marker, which for many people is going to be different, but the monoclonal protein, that M spike, or the increase in the light chains, either in the blood or the urine, that started up here, and now it's lower. To be a partial response, you have to have it get better by at least 50%. So the assumption is you've killed half the cells, at least, to have a partial response. Very good partial response is a 90% improvement. And then remission is you can't find it. And there's different categories of remission, because back 10 years ago we didn't have it. 15 years ago we didn't have that light chain test. So there were some people in remission, but then when the light chain test came around, you'd say, oh, well now I can see it. So they weren't. We would call you in remission last month, but now that we have this test, you're not in remission anymore. So they decided to call the old way remission still, but now stringent complete remission is if the light chain test is normal also.
Stringent.
Stringent. I don't, you know, I'm the messenger on that one. So getting to what you were mentioning, remission doesn't equal cure. Okay, that's the problem. Remission just means you can't find it. So there's a lot of, you know, breast cancer is kind of unfortunately a somewhat common disease. So some women will have a lump found, they'll go to the surgeon removes the lump, and the surgeon comes back and says, you know, we got it all. But, and you know, everybody's happy, but you better see Dr. Jones, the oncologist, just to make sure. And so Dr. Jones, she sees Dr. Jones, and Dr. Jones says, well, the surgeon got it all, and you can't find it. But there's a chance that some escaped out of where the breast surgery was done. And so we're going to give you a really strong chemo now to hope we can kind of get rid of it before it comes back, before it grows up into where then we can find it. And I kind of think it's the same thing that's important for myeloma. You don't want to wait till it's out of control and then use your good weapons, you try to get rid of it from the beginning. Women with breast cancer, they get the surgery and then they get really strong chemotherapy, even though they don't even have it detectable in their body, because it's better to kill it when it's down than to wait for it to grow back and then, oh, now we can see it, and then treat it. So I think that's the same way I view multiple myeloma. The cells divide, the myeloma cells. So every time, that one cell divides, it doesn't divide normally. If there's a cancer cell, its genes make mistakes. That's why it became a cancer cell. If the cell divides, it splits into two, it's supposed to make two perfect copies of itself. That must not have happened, because this one, there was something different here. So whatever the mechanism, the cancer cells make mistakes when they divide, and you have 1 million of them dividing every week, just to pick a number, there's more of a chance that a new mistake is going to happen, and then that's the cell that's going to be harder to cure. So I think it's better to try to have 1,000 cells hanging around than 1 million cells hanging around. Just to kind of show you with the thalidomide, people looked at using thalidomide after a transplant. And the people that had in this case in France, they did 2 transplants back to back. But the people that took the thalidomide instead of the people that had no treatment after the transplant, these people are living longer because they stayed on treatment. Here, they had chemo, they had 2 transplants, so really, and then they just watched them. Well, again, some people are like that guy I saw earlier today. They lucked out. He's the winner. But if you take 100 people, or 200 people in this case, these 200 people 8 years later are doing better than those 200 people. So that's why taking something after the transplant is better. Thalidomide, though, is hard for some people to take. It makes people's feet go numb. Yes?
If you're on say you're taking thalidomide,